Hello, welcome back to the second segment of medical and psychological restoration of rural areas. Again, I'm David Beach, and we're going to be discussing, instead of the first segment of the lecture where we discussed some of the gaps related to providing psychological and medical treatments in rural areas. This time we're going to talk a little bit about some of the models that are out there, some of the approaches, some of the legal issues or laws that have been enacted, trying to decrease those gaps and increase access so that an individual that chooses to live in a rural area has the same access to health care and medical services as their urban counterparts. One of the big issues that we discussed earlier is that the high financial barrier to mental health services, especially even if you are lucky enough to have health insurance. A lot of times, that health insurance, if you live in a rural area, doesn't include mental health care. So the Wellstone-Dominici Mental Health Parity Act of 2008, which was enacted on October 3rd of 2008, requires group health plans of businesses with more than 50 employees to provide treatment for mental illness that is on the same terms and conditions as other services. So if they provide other health care benefits, they have to provide mental health at a level equal to those other benefits, meaning that they can't say, all right, you can have a copay to visit the doctor for $5 copay, and then say, well, but if you go to a psychologist or a counselor, we're going to make you pay $50. It has to be fairly level in terms of what they offer. The good news is expected to provide over 113 million people with expanded insurance coverage. It will specifically benefit people that work for larger employers in rural areas, but again, as noted in that last bullet, there's a lot of people that are self-employed. There's a lot of people that work for small businesses in these rural areas, and they still don't have that right. So the President's Subcommittee on Rural Issues and the New Freedom Commission is still working to provide that same access to those services for those people that have chosen to live in rural areas. One model that they're looking to expand, and this is probably a controversial model, but private health insurance, as it is sometimes as advanced as it is and beneficial it is in medical treatment, as far as mental health, it's not quite kept up with the need for rural residents. So many times people that receive Medicaid are in much better off in terms of mental health care. And it's the largest payer of mental health services in the U.S., and 26% of mental health care in the nation is provided by Medicaid. It covers mental health services delivered in the home, school, or the workplace. So there are many advocates out there that but there's while it's important to say that the Medicaid model it has its glitches there. There are a lot of issues. There are lots of oversight issues, cost overrun issues. They think there's a lot of advocates though that still feel that model is beneficial and could be used to address mental health care issues in rural areas and work on improving linkages between primary care physicians and mental health specialists. That and many of your primary care physicians may not realize that the special groups that are out there, the specialty psychological mental health fields that are out there, and make sure that they utilize those resources either to gain information, gain referral, gain training, make sure those connections are there. So that's sort of addressing, how to close those gaps for psychological services in rural areas. one of the biggest probably boosts to providing services in rural areas in terms of medical services comes through the Patient Protection and Affordable Care Act, which specifically focuses on expanding rural health care providers. And there's several slides here that we'll talk about that. But a lot of this healthcare law focuses specifically on rural medical services. The first item, the Rural Physician Training Grants. So they're grants to medical schools that develop programs to specifically recruit students that are most likely to practice in underserved rural areas. And while these programs currently exist, scholarship programs, this is going to be expanded. The National Health Service Corps, which advocates for medical, persons providing medical services in rural areas, the funding for that group is going to be increased. Also, there's going to be grants to support new primary care residency programs. One of the issues that there is there aren't enough general practitioners. So a lot of because it takes longer to train a general practitioner than it does a specialist. Specialists have a difficult time providing services in a rural area, therefore end up in urban areas because of their specialty. But you still end up with not enough quality general practitioners out in rural areas. So, these increased primary care teaching capacity, that's going to increase the number of primary care residency programs, and there'll be more physicians that will be, can work out in rural areas. And then they'll give priority to those with affiliation with AHECs, which provide services to minority groups. Other provisions of the Patient Protection and Affordable Health Care Act is more rural graduate medical education, focusing more on training medical residents in community-based settings, rural health clinics, federally qualified health clinics. So there's a twofold approach with that. You try to get physicians working in rural areas, enjoying working in rural areas, making more likely they're going to stay in the rural areas. And then also, while they are still interns or residents, you've increased access to mental or medical care by having those residents at those health clinics. Also looking at redistributing residency slots. If there are unused slots in primary care, they're going to, in urban areas, they'll move those to states with low physician numbers and large population and health profession shortage areas, which is typically going to be rural areas. There's a workforce loan program where if you are working or going to work in a specialty and then go work in a health professional shortage area, they will give you a low interest loan of up to $35,000. There's also a U.S. Public Health Sciences track where they're going to select sites for team-based service in public health and emergency preparedness, and focus on graduating physicians, dentists, public and behavioral health professionals, nurses, physician assistants, and focus on this. It's going to start at a certain point in high school and track those students into college and then on through these professional services, and they're going to focus on underserved areas. So, it's more likely, as that first quote stated, that it's more likely that persons from underserved areas will go back to an underserved area. Maybe where they're from, or it may be someplace similar. It may, they'll go back to a rural area because that's where they feel comfortable, that's what they understand. Other provisions, expanding more healthcare providers such as nurse-managed health clinics. Many of the clinics will have, there's been an increase in nurse practitioners. And in many states, they have very similar ability to practice as physician or physician's assistant. So they'll be utilizing these health clinics with nurse practitioners or RNs administering those. Better student loan programs for nurses. More training opportunities, more tuition assistance, more training in general pediatric and public health dentistry, grants to focus on meeting the needs of rural populations. Again, as we move to slide 15, there's more of more provisions related to expanding the number of providers. More nursing workforce programs, meaning that many workforce programs have focused on LPNs and your nurse aides and some of your other medical service providers, first responder services. And a lot of times that's gone through workforce programs and your community colleges. So more money will be given to those, including advanced nursing education grants and quality and retention grants. For the first time here, we talk a little bit about more mental and behavioral health education grants that are given to institutes of higher education for recruitment, educations, and social work, education of students in social work, psychology, and child mental health, and they'll be given a priority to programs producing professionals serving high-need populations, which of course includes rural areas. And also some demonstration grants that are mentioned there for nurse practitioner training and trying to move those nurse practitioners into health clinics. I'd predict there's going to be, as it becomes more difficult and while there is going to be a greater push to get general practitioner physicians, there's also going to be expansion of nurse practitioners and the role of the nurse practitioner and the role of the physician's assistant, and probably some expansion of the services that they can provide in rural areas that will help fill this gap. Now we moved on to some of the changes that the law has sort of the efforts for rural hospitals and clinics, some of the changes that are and improvements and issues to be addressed by the new law. The first is just expansion of medical care facilities in rural or underserved areas. Major component, $9.5 billion to a new community health centers fund to expand the operational capacity of health centers and clinics. They're thinking it's going to be right around 20 million new patients. $1.5 billion over 5 years to help community health centers meet new construction and expansion needs. So not only is it going to expand the current services, but they'll be able to build more services, and that sort of levels the playing field. Urban hospitals have the population base to draw the income it takes necessarily to operate. Rural services, rural hospitals are going to provide the same services. There has to be something that levels that playing field, and grants give that ability. a lot of grants in terms of medical schools, institutes of higher education, nonprofits, community-based organization, especially those relating to workforce expansion. And the great thing about all this money is that everything is tied back with, working with community mental health centers, rural health clinics, or areas that where there's shortages, which is generally rural areas. So, as for, in terms of this Patient Protection and Affordable Care Act, otherwise known as the new health care law, there's a lot of uncertainty and controversy around it, and I was on Capitol Hill at the time that it was enacted, and there was a lot of stress and a lot of consternation, and there's still a lot of confusion as we roll into the time when it becomes enacted of some of the provisions. However, the more we read in terms of the disability field of rehabilitation, there's a lot of benefits, especially for those that don't have access right now. Already and we're not even all the way through. We've seen, major emphasis placed on, getting qualified, trained professionals, not only just physicians, but nurse practitioners, physical therapists, mental health practitioners, all sorts of folks in this medical and psychological restoration area, hopefully level that playing field. In slide 17 here, we talk about prescription drug discount program. Apparently, and I didn't know this until I did a little bit of research, rural hospitals could not participate. But the new law allows rural hospitals to get prescription drugs at a discount, so they can then sell them at a discount to their people receiving services, reducing that cost and financial barrier. The new law contains provisions regarding payment provisions for rural hospitals, Medicare payments. There will be extensions. They'll get a 3% bonus payment for home health care services in rural areas. So there's incentives out there for hospitals that are expanding and providing services in rural areas. Another area related to, and we won't touch on this a lot because we're not really talking a lot about, in rehabilitation, we don't really talk a lot about emergency services, but again, the quality of emergency services will impact the future functioning of the individual. I was recently at the opening ceremony of the World Equestrian Games, where one of the performers for the opening ceremony fell ill, and they were, just happened to fall off his horse. Well, when he did, he fell right into the right beside some medical staff that were on site, and they were working on him in seconds and providing CPR and doing chest compressions within just a few seconds of whatever illness came about. So subsequently he survived. So now, so the issue is, having that access. The closer you are to a medical professional during an emergency, the more likely you are to survive and get treatment and, hopefully have better functioning than if you had to wait 25, 30 minutes, an hour, 2 hours, 3 hours. And one other issue about rural emergency services, I don't think we really talked about it yet, is that because very few people have insurance and access to care, they know that if they go to a emergency room, they'll get service of some kind. Because most hospitals will take some charity cases. So what happens is the emergency room ends up also being the catch-all, and they have to do a lot more. There's a lot more demand because, first of all, there's not a lot of preventative care. There's a lack of preventative care and a lack of health insurance. So that's where they go. So they have a huge demand. And we talked about a lot of times because they're smaller hospitals, they don't have enough staff. They rely on a lot of volunteer work, and tend to have greater cost per patient. So the Patient Protection Affordable Care Act provides some payment incentives. It increases some fees so that they can increase and expand services, rural emergency services in these areas. There's in some cases up to a 22.6% bonus payment for some of the services they provide. And they also talk there in that last bullet of just some continued study about rural emergency medical services and how important it is to address many of the issues that are impacting rural services and just emergency services in general. In this last slide here, there are mentioned in the new act the community transformation grants, which grant funds to state, local, tribal governments, nonprofits, national networks for implementation, evaluation, and dissemination of evidence-based community preventative health activities to reduce chronic disease rates, development of secondary conditions, etc. So not only are these grants going to focus, or is this is the Patient Protection Affordable Care Act going to focus on treating disease and mental health, but it's also going to focus on preventing and putting funds out for study and I like how it's given these grants. It's not just limited to hospitals and certain groups. It's a very broad group that are going to be able to apply for these and look at global ways to address preventative health. Let's see, one other item of note in terms of addressing the gap in medical restoration in rural areas is the primary care extension program. For those of you that live in rural areas, and we talk about this more in the section on agribility, extension agents are usually present employees of the land grant institutions that are there to provide services to farmers throughout the state, rural workers, agricultural workers, homemakers. One model that is being utilized is this extension agent, and instead of the land grant extension agency, this program has a health extension agent to provide support and assistance to primary care providers. So, right now the extension agent goes out and trains the farmers. They train people to work with farmers. They provide services. They work with homemakers. Well, this health extension program provides support. And it doesn't provide it to the citizens of the rural, residents. It goes to primary care providers, service providers, and talks about things such as preventative medicine, health promotion, chronic disease management, mental and behavioral health, and evidence-based practices. So that extension agent will work in that community. And the thing I like about this is they'll work in the community and they'll understand their community. They can meet the needs, they can assess the needs of their individual community. Just like with rural extension agents, you have a state like Kentucky and you have county extension agents. Well, in certain counties, there may be certain crops that are more being grown more often, such as tobacco, where you move into other counties where they grow more corn. So those, the extension agents in the counties that grow more corn, well, they provide more training around growing corn, and the ones in the areas that grow tobacco, they focus more on training folks how to use tobacco or how to raise tobacco. Same thing with the health extension agents, in that they, if there are more problems with diabetes in a certain area, then they work with physicians on meeting the needs of persons with diabetes, do more training, they arrange more resources. In another area, it might be more related to mental health, so they'll provide more information related to mental health. So it's an individualization on a small scale to help meet and address those issues. So with this, with this lecture, I hope we have, first of all, cleared up some of the misconceptions about the Patient Protection Affordable Care Act, and see how, as intended, if the law is enacted as it was intended, was written, huge potential benefits for our rural consumers. And while it is a lot of pie in the sky, it's good to see that in this act that the needs, access needs for persons in rural areas were truly taken into account. And it will be interesting to see, as this law sort of progresses, the potential impact. So with that, I want to thank you for your time and attention, and we will move on to the next lecture.